My name is Susan Blacker. I'm one of the directors for the American Society of Addiction Nursing. And tonight we're having a webinar on understanding the perinatal population at risk. This webinar has been approved for one continuing education through the California Board of Nursing. At the end, you will receive an email that will have you complete a survey. And then once you've done that, you'll receive another email with your certificate of completion. Okay. If you've missed a session, all the sessions are recorded and are archived on the website. And if you're a member, you can view any of the archived sessions for free. Otherwise, if you're not a member, then you'll have to pay the fee per session. The CE is available for live or on demand, and you will receive your certificate after completing the survey. So we want to see you, so please keep your cameras on, but mute your microphones. I always say post your questions in the chat, but I do know that Rosemary and Tony will take questions. They usually do. But if you don't want to speak out, please put them in the chat. Okay. Today's webinar is presented by Tony Primus and Rosemary Smentowski. Tony is a certified addictions registered nurse and has worked in the field of substance use disorders, maternal child health, and pediatrics for over 20 years. Her experience has been primarily in substance use disorder treatment, including MAT, inpatient, outpatient rehab, and maternal child health. She's most proud of her work in the field of substance use disorders and maternal child health. She's a member of Sigma Theta Tau Nu Eta chapter and the American Society of Addiction Nursing. Board appointments to Health and Addictions Board, and a state appointment to the New Jersey Maternal Mortality Review Committee. She has presented nationally on numerous topics related to substance use disorders and also published in various journals. She graduated from Rowan University with a BSN and Drexel University with a master's in nursing. She is currently pursuing a postmaster's doctorate in nursing at the University of Pennsylvania. Rosemary is certified in addiction nursing and is a psych mental health nurse practitioner. Her experience includes fetal alcohol reduction, FDA study drug coordinator for LAM, methadone maintenance, and detox. She has served as director of nursing for Therapeutic Community and RAMP, New Jersey's Alternative to Discipline program, and is currently appointed to the RAMP Oversight Committee. She's employed as an adjunct professor at Georgian Court University and Monmouth University in New Jersey, educating pre-licensure and graduate nursing students on psychiatry and evidence-based mental health. Rosemary is employed as a psych nurse practitioner at New Hope Integrated Behavioral Health in Marlborough, New Jersey. She's a member of numerous nursing organizations. She serves as president of the Addiction Nursing Certification Board. Rosemary presents nationally on the role of nursing in treating substance use disorders and the importance of certification in this specialty. Rosemary promotes nursing as a profession and addiction nursing as a specialty, and believes nurses are an untapped resource in combating the disease of addiction. I also wanted to tell you that next month we're having a webinar on, just had it for here, mindfulness-based interventions to support abstinence and sustainable recovery. So if that's of interest to you, it will be available on the website to register for it. So without further ado, I'm going to turn it over to Tony and Rosemary.
Hi, everyone. I guess you can see Rosemary and I present and we are crazy. So when we present, we really like to have an open conversation, more of a conversation, and we love feedback from our participants. So feel free to put questions in the chat and I'm sorry, my dog is barking in the background. This is her time to bark at the people walking by. Feel free to put questions in the chat or just raise your hand and we'll try to answer as best we can. We are very open and honest about if we don't know something, we will find out for you, but we will say that we don't know, we're not familiar with the subject or something that you're asking the question about. So, but as you can see, both of us have been in substance use disorders and been trained and are certified addictions registered nurses and proud to be nurses. And we've had a lengthy career in that. So I think we know a little bit about what we know about. So that being said, thank you guys for coming and thank you for your interest in this topic because it's such an important topic. And it's a passion for both Rosemary and I. You know what? I have to change my, okay, I'll just minimize it. The objectives for today are to determine the population-based risk of substance use disorder, identify culturally competent risk assessment strategies for substance use disorder detection, and to review self-assessment tools for use and evaluation of substance use disorder. Okay. First, we're just going to give you a little data on some of the topics. I mean, some of the perinatal risk, and I'm not sure of what specialties everyone comes from, but obviously you have an interest in perinatal risk and understanding those populations at risk for substance use disorder. According to SAMHSA's latest national survey on drug use, a number of pregnant women with opioid use disorder has more than doubled, and the number of infants born with neonatal abstinence syndrome, which I'm told has changed to NOWS, NOWS, neonatal opioid withdrawal syndrome.
Withdrawal syndrome.
Did you say something?
No, you're good.
Okay.
Just yeah.
It has grown fivefold. So, and that was according to a survey in 2017. So I'm sure it's post-COVID much more. 4.4% of pregnant women ages 15 to 44 used illicit drugs. And the 2012 report it gave us statistics on the NAS diagnosis, or neonatal abstinence syndrome, which is 3.39 per 1,000 births per year. 55 to 94% of drug-exposed neonates developed neonatal abstinence syndrome. Some facts about opiates in pregnancy, and these are from the most recent national survey on drug use and health. And the number of pregnant women with opioid use disorder has more than doubled, as we said before. And reducing these numbers means getting pregnant women with opiate use disorder the healthcare that they need to reduce the chance of perinatal opioid exposure and NAS. There are, and I guess maybe we should have put this slide at the end. I'm looking now. But for those of you that are treating opiate use disorder during pregnancy, or come in contact with women that have opiate use disorder, there are some great tools out there on the SAMHSA website. We have references at the end of our presentation. And there's a great toolkit out now that has literature and a lot of handouts on healthy pregnancy, healthy baby, opioids in pregnancy fact sheets. And they are actually developed on like a 6th grade reading level, but great tools to have in our toolbox. Risks of opioid use disorder during pregnancy. There are several things that affect the unborn baby, and with untreated opioid use, primarily being the fluctuating levels of opioids in the mother, and that may place the fetus into repeated periods of withdrawal, which is harmful for placental function. And other direct physical risks are to the fetus are neonatal abstinence syndrome, or NOWS, stunted growth, preterm labor, fetal convulsions, and fetal death, and more other indirect risks to the fetus, which are increased risk for maternal infection, such as HIV, HBV, and HCV, and malnutrition and poor prenatal care, and dangers from drug seeking. I don't like to call it drug seeking, but dangers from illicit drug use. And one of those being that we don't think about a lot, intimate partner violence, or just violence in general, due to the environment, and also incarceration. Oops, I'm sorry. One of the important things that I think is challenging for all of us in healthcare is substance abuse screening and assessment, and acknowledging that screenings and assessments are so important and are conducted as an information gathering. A lot of times I know you're on a time constraint when you're treating patients, but it is so important as nurses to have that screening and assessment, because we are the initial contact between a woman and a treatment system. And that even goes for when a woman comes into the emergency room, and her point of contact may only be the emergency room if that woman hasn't had prenatal care. So it's important to do screenings, and we're going to talk about that a little bit more in the presentation. I'm not sure if I agree with this, but self-administered tools are more likely to elicit an honest answers, but and that's especially true regarding questions related to substance use. I do feel that being a certified addictions nurse, that there is a way of asking questions that may elicit more honest answers if you provide an environment to be able to answer the questions in an honest manner, because it's more of a safe environment for a woman that has some contact with a treatment system. Face-to-face screening interviews may not always be successful in determining alcohol and drug use in women, particularly if the practitioner themselves is uncomfortable with the questions, which is why actually Rosemary and I do these talks, because we feel that practitioners, well, everyone in general can learn how to provide an environment of comfort for women that are seeking help, really. And the last thing is selection of screening and assessment instruments that should be examined to determine if they were developed using female populations. So that's something that we can advocate for as practitioners. The next slide, I think, is a good visual of the screening and whose job is it anyway? Whose job is this anyway? I mean, so many people come in contact with a patient with substance use disorder, but some of it is how we identify substance use disorder in our professional lives, and also in our personal lives. What about social services? Or definitely social services, but it's not only social services that should be involved in providing that environment for the patient where they feel comfortable in seeking help. And the nursing profession, absolutely, it's our job to screen. We call it SBIRT, which is screening, brief intervention, and referral to treatment, which we'll talk about a little bit later. And identifying the art from the science of nursing. And I think that a lot of us can identify with the science of nursing, but there is the art of nursing as well. And I don't know if that's something that you can teach, but that's something to think about. Advocacy, attending and caring for the patient. And can only persons in recovery care for patients with substance use disorder? I think that everyone can care for persons with substance use disorder. Nurses are in a unique role to bring themselves to a part of this nursing role. And on the other end of the spectrum, we do have to acknowledge that we as nurses are human, and we have some transference or countertransference because of our own experiences with substance use disorder. And also to acknowledge that we do have addiction in the nursing profession as well. I don't know, Rosemary, do you want to take over the you're on mute.
So yeah, we're not going according to the original plan.
What was the original?
I don't know. We're doing new, right? Okay. I mean, I'm game. You just tell me when you want me to stop. Is that good?
Yeah, let me see. Oh, we were going up to, I'm sorry.
Yeah, I mean, I'm fine with it, but go ahead.
I can do that one, and then you're going to take over the methadone.
Yeah, I think that's what you were headed me for. Yeah.
Okay, cool. All right. So nursing defined. Um, the Addictions Nursing Certification Board is part of.
I'll do it. You want me to do it?
Yeah.
Okay. So this actually, this wasn't in here in the last thing, but Tony and I don't live anywhere near each other, but we love to do this long term, and we're both in doctoral programs, so we haven't been connecting as much as we do. But the reason why nursing, I believe, is so important to our patients, in addiction, is because we treat the human response, right? We don't treat a diagnosis, we treat the human response to whatever that diagnosis or feeling might be. So nursing is the protection, promotion, optimization of health and abilities, prevention of illness and injury, facilitation of healing, alleviation of suffering through diagnosis and treatment of human response and advocacy in the care of individuals, families, groups, communities, and populations. I'm telling you, this is from the American Nurses Association in 2015. And the definition has been, buffed up again. But for the purposes of substance use disorder, I think this fits us very well. And, working in substance use disorders, I'm surrounded by people who are like-minded with the disease. I'm doing clinicals in a teaching hospital where they're not really nice to our patients. In fact, my doctoral project is on the assessment of nurses' perception of patients with substance use disorders on a psychiatric unit. And it was actually something that the nurses noticed, that even on psychiatry, our substance using patients are not being treated the way they should. They have some kind of a bias. So hopefully we're going to make a difference in this. And the more people like you that come and get certified and listen and learn, the better off our patients are going to be. Tony, you going to go to the next slide?
Okay.
I've got you. So routine screening. For me, routine screening, I do this all the time because I'm eating and breathing addiction, where I work in inpatient. But routine screening does more than just find out who's using, who's not. It should be used all the time just to normalize the conversations that we have with people. As it stands right now, most patients are only asked about substance use when we think they have a problem. So of course they get defensive, right? But routine screening should promote for all nurses, not only in the prenatal setting. I'm fighting for this across the board. Just like we ask any other question, we ask patients a whole lot of personal questions. And this should just be one of the things we do when we talk to people and monitor blood pressures, temperatures, pulse rates, screen them for substance use disorder. But screening should include substance use disorder, depression, and smoking. We know how these impact our pregnant patients, right? Screening pregnant women is the perfect time to discuss all aspects of care, including substance use disorder. And the beauty with pregnancy is, as nurses, we're great at building that rapport. And we have like an audience for the next at least few months, and then for a couple of weeks after. So engaging with all pregnant women about substance use disorders and carrying this conversation is important for us, right? So we have this opportunity to spend this pregnancy time and postpartum time with them. The 4Ps plus screen is not available in the public domain. Instead, healthcare professionals can use the Institute for Health Recovery's integrated 5Ps tool, which was adapted specifically for pregnant women. And we know how important using the right instrument is for the right population, right? This is important for us to do. The questions in the 5P tool asked pregnant women about her parents' and her partner's past, present alcohol and drug use in a non-threatening manner. Because if we have a patient who, has just really doing the right thing because she's pregnant, but still living in a household where people are using, we all know what kind of a trigger that could be for our patients, right? And ultimately for their unborn child. The 4Ps Plus is used in New Jersey's public prenatal clinics and has had success in screening all pregnant women in that setting. Screening brief intervention referral to treatment model is applied. I'm from New Jersey. Tony's from New Jersey. I have to say, New Jersey is not really one of the states that promote Esprit. It came to New Jersey in 2005 or 2004, and I am in a facility that never uses Esprit. They didn't even know what I was talking about. I teach at 2 universities. I teach undergrad and I teach master's level, and my students didn't know what Esprit was in New Jersey. Go to another state like Massachusetts, Florida, you get such a better reception than what we have in New Jersey. So what I am proud about for New Jersey, though, is we're very proactive when it comes to domestic violence and for depression and postpartum depression / psychosis in New Jersey for screening for that. We're not so good at this, which is one of the reasons why Tony and I first started doing this. We did actually 3 webinars with the New Jersey State Hospital Association, and that's how we came together to do prenatal and pregnancy for other nurses. Tony, going to switch here?
Yeah.
You have to tell me you want me to stop. So here's your 4 Ps. Have you ever used drugs or alcohol during pregnancy? Have you had a problem with drugs or alcohol in the past? Does your partner have a problem with drugs or alcohol? Do you consider one of your parents to be an addict or alcoholic? And right now, what I'm looking at is, the language here is pretty poor. We use substance use disorder. We don't usually say alcoholic anymore, or addict, right? And this screening device is often used as a way to begin a discussion about drug or alcohol use. Any woman who answers yes to 1 or more questions should be referred for further assessment. And anybody on this call who thinks they want to rewrite this with patient-centered language, be my guest, because if you don't, Tony and I are going to be forced to do it, right? Okay, next slide. So evidence-based treatment, which has really advanced over time. Methadone was the gold standard. And more recently now, what do we see? Subutex, right? And we're finding that the studies really on Subutex, babies have less withdrawal syndrome after birth, right? So buprenorphine and methadone have both been shown to be safe and effective treatments for opioid use disorder during pregnancy, while we call, neonatal withdrawal syndrome now may still occur in babies whose mothers receive these medications. It's less severe than in absence of treatment, and it's less severe with Subutex by days than it is with methadone. What used to be pretty prevalent was if mom was ready to be weaned off of methadone, breastfeeding by mom in decreasing doses of methadone was a way to detox baby gently. But, that's not always, we're not in a perfect world, and it doesn't always go that way. Research does not support reducing medication dosing to prevent neonatal withdrawal syndrome, as it may lead to increased illicit drug use, resulting in greater risk to fetus. Not only that, a recent webinar I attended had to do with maintaining women on their psychotropic medications, because they're finding that, moms need to be stable after delivery. This is a very, very serious time for mom emotionally, mood swings, hormones, and moms with bipolar. And the new studies are showing that dose matters, but keeping mom safe and infant safe is very, very important. Next slide, Tone. So methadone versus buprenorphine, a recent meta-analysis showed that methadone is associated with higher treatment retention. Don't forget, methadone is daily in the clinic every day, eyeballs on, right? However, buprenorphine resulted in 10% lower incidence of withdrawal in the infant, which look at that in health and well-being of the infant, in dollars and cents for the hospitals, right? So it makes a difference on a lot of different levels. And sometimes when we want to see something change, we have to talk in dollars and cents, even though that may not be where our heart lies, right? So decreased neonatal treatment time by 8.46 days. That's a big deal. Less morphine needed for the infant at that time by 3.6 milligrams. Patients should work with their doctor to determine which medication is best for them. And don't forget, right now, we're in a situation where buprenorphine can be prescribed by anyone without an X waiver, right? So practitioners I'm seeing in the hospital are using buprenorphine, they really don't know the ins and outs of it because they didn't have the training. But more patients now are being admitted to all units in the hospital on buprenorphine, and nurses are not prepared for this. They really aren't. So any of you that are certified in addiction, be heard. Okay, be heard. Tony, next slide. I don't know how far you want me to go here, so let me know.
Go ahead, you can.
Okay, so here's your benefits of treatment. Treatment with methadone or buprenorphine improves outcomes of the infant by stabilizing fetal levels of opioids, reducing repeated prenatal withdrawal, very serious time in an infant's life, right? Linking moms to treatment for infectious disease, HIV, hepatitis C, hepatitis B virus, providing an opportunity for better prenatal care and improving long-term health outcomes for mom and infant. Compared to untreated pregnant women, women treated with methadone or buprenorphine had infants with lower risk of NOWS, less severe neonatal opiate withdrawal syndrome, and shorter treatment time. Higher gestational age, weight, head circumference at birth are all positive things that are found from having mom controlled during this time on medication. You flipping here, Tony, for me?
Yeah.
Okay. So here's your ESPRIT, which, believe me, if anybody's out there from New Jersey, shout it out to whoever will listen. Screening, brief intervention, referral to treatment, evidence-based growing body of evidence, the effectiveness of brief intervention when completed by qualified health professionals. Brief initial screening, 5 to 10 minutes. Universal routine screening for all patients as part of standard intake. Everywhere, across all specialties. Tool addresses specific behaviors that are preconditional to substance use and dependence. ESPRIT was developed for use outside of substance treatment facilities, especially in emergency rooms. And actually, initially, ESPRIT was developed for physicians, and it was nurses that actually brought it to nursing as an hour role. And I might add that they were nurses who were certified as CARN and CARN-AP. So, provides a seamless transition from universal screening, brief intervention, brief treatment, and if indicated, to other treatments that may have more high acuity. So next slide. This is really important. I try to use this with my nurses that, I'm a consultant at my job. So I have a voice, but I'm a consultant and like my job. But the idea is, if we have a patient that comes in and, we say to them, on a 0 to 10, how you're here for treatment right now, at a 0 to 10, what's your level of really wanting to get into recovery, seek recovery, maintain recovery? And, I may have a patient that came there through, justice involved situations, and they may look at me and say, hey, lady, I'm a real 3. Really, I'm here because I'm in drug court. And if I'm not here, I'm in jail. And then what's my response? What do you think? Anybody going to shout it out here? Anybody? No? How come you're not a 0, a 1, or a 2? Like, if you're a 3, that gives me something to work with, right? I mean, anything on this scale, even a 0, we're going to say, bring it up to a point. Well, tell me why not? Or you're a 1, well, tell me why you're nothing. Why aren't you don't want any motivation for recovery? And the things to think about change, which we know about motivational interviewing, we also know that nurses really don't get enough of this in their training. What changes are you considering? How important is it that you make this change? How confident are you that you're able to make this change? And how ready are you to make this change? And I will say that our pregnant women usually have like another layer of reasons to want to seek change at this time in their life, which works in our favor when we're dealing with pregnant women.
Okay. Yeah, this is one of the most important times in a woman's life where she is most receptive to change.
Right. I'll be honest with you. I don't care how a woman presents to me for treatment. As long as I have her there, she's there. Right. So how we can get her to think in a different way, that's our job.
Absolutely.
How am I doing? Am I good, Tom?
Yeah, it just, you can do that. I'll voices of the patient. I think that's
Okay.
really important. And then I'll jump in with improving engagement.
Okay, so how these came about were Tony and I had done those 3 webinars for New Jersey Hospital Association, and we actually connected with a methadone clinic that had a perinatal program there. So these were what were said by patients who were in the program at the methadone clinic. Judgment for being on methadone and judging for high dose. Methadone is recognized as the gold standard for treatment of pregnant women with opiate use disorder. One of the patients actually mentioned that her in-laws didn't know that she was on methadone. And this became a big deal when she got to the hospital, and the nurses on the obstetrical unit made a big deal of this and said that what should have been one of the most blessed times of her life had turned into a nightmare, which was really sad. The other thing is pushing towards supplementing with formula instead of respecting breast is best for because newborns need colostrum. And we encourage breastfeeding as long as mom maintains abstinence and is not HIV positive. So sometimes nurses not in the know about evidence-based treatment with substance use disorders in pregnancy are kind of pushing the envelope on patients who have an idea of what they've already decided they want to do as a mom, right? And they get discouraged because people really don't know what they're talking about and they're pushing it on the patient. You good now, Tone? Where are we here?
We're good.
Okay, I'm doing this one too.
One,
Okay. Yeah, this is okay. So this is from Jersey Shore Addiction Services, and the patient said, "I felt that my rights as a patient were violated in many ways. I've been on only prescription medication for over 6 years with no drug usage and all clean toxicologies. I even gave my OBGYN and hospital a copy of my toxicologies. DCPP, which is our Child Protective Services, were called while I was at the hospital, and they told me it was state law to call on patients on medications giving birth." And this was really sad because this woman delivered in 2019, and New Jersey changed that law in 2018. New Jersey was really proactive in saying that as long as a mom went to a hospital and was adherent with her methadone program, they didn't call the state. So this was like a shock for people that didn't know the law had been changed. The attitude of the nurse and social workers who immediately thought I was shooting heroin because I was on a methadone. So sad, right? Maintain contact with this outpatient, opiate treatment facility for patient dose and adherence. And then judgment on doses and amounts, ignorance on dose amounts for pregnant women. And we know that pharmacokinetics during pregnancy must be individualized. Methadone metabolism rates accelerate during pregnancy due to an increase in CYP3A enzymes. And in many cases, I've worked methadone. I've done a study drug, methadone for the FDA and NIDA. And many of these women, rather than increase the dose initially, unless it's absolutely needed, we do a split dose on pregnant women, especially if they're rapid metabolizers at this time, right? Okay, so I'm going to turn you back over to Tony.
Okay. So I'll talk a little bit about improving engagement. And I think that the whole purpose of the talks that Rosemary and I do is to help to improve engagement and help to educate nurses in general on no matter what specialty you're in. I think substance use disorder crosses all all areas of practice for nursing. Stigma and bias among healthcare providers results in number one, underreporting drug use. And the second is insufficient medication dosing that leads to ineffective treatments. I think Rosemary referenced the dosages, and sometimes you have to have that conversation just like you would for any patient on their medication regimen. The fact is that further along in the pregnancy, a woman may need an increase in medication of Subutex or methadone towards the end of her pregnancy. And that's okay. It, it's individually based, just as insulin or any other medication that you would use long term for blood pressure control, diabetes. We have to normalize this and not make it a judgment based dosing per se, and not to stigmatize the woman, because this further promotes that they're doing something wrong by even seeking treatment. So off my soapbox, but let me 18 states classify maternal drug use as child abuse, and 3 states consider it a reason for involuntary hospitalization, which discourages or decreases a woman from seeking treatment in the first place. As Rosemary said, in 2018, New Jersey changed their law, which is somewhat punitive, that DCP&P or our child protective services have to be notified every time a child is born to a mother that is actually in treatment. These women are in treatment for their disease, and Child Protective Services is called. Now, most of the time, if they are in treatment, they don't open a case for DCP&P, but they will monitor to make sure that all services are in place for mom and baby, which is something that's a positive thing, for DCP&P, as they have to be notified. But Rosemary and I can attest to the fact that years ago, and there was great communication between Child Protective Services and the substance use disorder treatment centers, where there was a trust that if the woman was in treatment, they wouldn't be called. DCP wouldn't be called or involved. So that has changed, unfortunately, and is another deterrent for women to actually seek treatment during pregnancy. And women who are allowed to stay and bond with their children during treatment are more likely to remain in treatment and maintain abstinence. Something that we didn't include in here that I want to make sure that we do cover is the fact that there needs to be more an improvement in engagement with mothers who are in treatment, and even the mothers that aren't in treatment, post delivery. That is a very not difficult, but I would say it's a very touchy time where a woman may relapse. That's a high risk time for a woman to relapse, in particular, because if she hasn't had a good relationship with her prenatal provider in making a plan for pain control and other things after delivery or during and after delivery, she may be tempted to relapse at that time. So that's when she needs even more services and more assistance. Stigma and discrimination. We should all change our language to people first language that respects the worth and dignity of all women. Focus on the medical nature of substance use disorder, and not the stigma of the disease being something that the patient is able to control. Promote the recovery process, trust building through clinical conversation, and the use of questions like, what is the most important thing to you about treatment or recovery? And do you have any fears or concerns from previous treatment or recovery experiences? And what do you need to feel safe? And finally, use empathy. The ASAM definition of addiction that was adopted by the ASAM Board of Directors in 2019 says that addiction is a treatable chronic disease involving complex interactions among brain circuits, genetics, the environment, and an individual's experience. And people with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those that have other chronic diseases. Some of the professional barriers that we would like to address would be lack of training for training to screen for substance abuse, which is something that Rosemary and I try to do all the time, is promote training for substance use disorders, and help to decrease the misunderstanding of chronic relapsing as substance use as a chronic relapsing nature of dependence, and unaware of treatment options or community resources, the skepticism that treatment for illegal drug use is not effective, and the lack of knowledge. I think all of these things tie together when you're talking about professional and personal values or personal value barriers that we have, such as an unresolved personal experience. Maybe you yourself or a family member has had substance use disorder issues. The fear of liability for a lot of nurses, enabler giving approval by not asking those questions or not having a conversation about substance use disorder to your patients. And then a bias against methadone. And methadone and Subutex are used in general to treat substance use disorder in pregnant women. And discomfort yourself with the topic, and fear of losing the client by asking some of those things. And then finally, planting the seeds. Nurses consistently remain the most trusted healthcare professionals. We have a connection profession. Even though it's our profession, it is an art, and we do connect uniquely with patients that is so different from any other profession. And we have a chance to be able to influence the people that we treat. Substance use disorders, like all chronic progressive diseases, are best treated by early identification, intervention, and treatment. And I think that we have to really get the word out that substance use disorder is a chronic progressive disease, just like any other. And empowering nurses with evidence-based education on screening, brief intervention, and referral to treatment. For routine screenings of all patients, normalizes a conversation and decreases the stigma surrounding substance use disorder, in particular for women, pregnant women, which is a very vulnerable time in our lives. And also that there's currently no wrong door approach. I think, Rosemary, you can speak more about that, since that's something that you often say, that there is no wrong door to approach treating substance use disorder. So if you want to expand on that.
Well, that's one of the reasons why we need to be there's the positive and negative sides of having, you know, a medication like Suboxone available for prescribing to anyone who has a DEA license and can prescribe, you know, any controlled substances. The problem is, even when we needed a waiver, only 4% of the people with waivers were actually prescribing. So we have a real problem with practitioners not willing to kind of take care of those patients, or thinking they take too much time, or not wanting to start something that they're afraid they'll have to continue. And we also do another very bad thing, where this is the only disease where if something doesn't work for you and you have a slip, we throw you out. You know what I mean? Like, we can't do this. We can't continue to take people when they're most vulnerable and throw them out of treatment for an infraction. So we have to find better ways to negotiate with our patients to keep them in treatment, to keep them comfortable, to not be so judgmental about what are things that at that moment in time are very important to them. At least hear them out and then explain why we're doing things. But you know, in Europe, there was a study in Europe, and I can't remember who it was, but the thing that impressed me was the nurses in Europe said that they can't understand why nurses in the United States would rather treat the consequences of substance use disorder, like HIV, hepatitis C, violence, rather than do the prevention, because Europe is all about the prevention. So here we are, and to European nurses, we look like we're okay with just letting this happen and then treat the consequences, which we really need to turn that around. And this is Tony's idea at ending in a happy place.
So just leave, we plant the flowers and let them grow. So thank you guys for listening to our presentation. And if you have any questions, we'll be happy to answer.
I do have one thing that I think is very important for you to know. When I was working in methadone years ago, there was no such thing as detoxing a woman from, you know, her either methadone or any stuff. We had to maintain her on methadone so that the baby wouldn't die in utero. But right now there are studies where women are being hospitalized for 1 to 2 weeks with a neonatologist and being detoxed off of medications, especially if they were on MAT and they think they're ready to come off. So methadone and Suboxone, yes, safe, but in some cases right now, the unheard of is that women are being detoxed during pregnancy. And their main reason is so that the baby will not go through withdrawal. But you have to remember that we don't have babies that are addicted, because babies can't meet criteria for addiction. That, you know, they don't crave, that, you know, we don't have that. So babies aren't addicted. So that's why the NOWS, you know, the neonatal opiate withdrawal syndrome is what the term is that they're using for now.
We have a question about alcohol use disorder.
Let me see, what do we got?
From Jill.
Oh, alcohol is scary because you have to take them off of the alcohol. We have to really do a taper. And you know what I'm going to tell you? I work in inpatient substance use treatment that we have detox, male, female, and adolescents, and then short-term rehab. We do get women in. Very easy to flip somebody from opiates into Suboxone or on methadone, right? Alcohol is very tricky and needs to be done with a neonatologist and an addiction specialist. And you know what I do? If I have a patient that I have to prescribe for there, I want to talk to the pediatrician, because ultimately the pediatrician is going to have that patient. So I would say 3 people and the pregnant women have to be consulted on what's going on there. But alcohol, very serious. I would
Are there
say
medications for alcohol withdrawal for pregnant women?
Librium or Valium, Librium mostly. That would be it. And the benzodiazepines apparently, I mean, we're looking now at keeping people on medications for bipolar. So there's other meds that we always said hands off of everything that they're now taking a second look at, because our women are coming into this not well, medically or psychiatrically, and they need to be both in order to care for this infant. So careful withdrawal, I would have to, for me personally, I wouldn't do it unless the patient was hospitalized. I would make sure it was that they were hospitalized. Tony, you seen anybody alcohol withdrawal outside of hospital?
Not for alcohol, no.
No.
That's a serious.
Or benzos.
Yeah.
Or benzos.
Yeah.
Too
And
dangerous.
they keep them on the benzos. They'll
Yeah.
keep them on. Yeah.
So Librium would be what they would detox for and I did have one patient that they did use phenobarb.
Mm.
You have to really worry about seizures.
Mm-hmm.
Yeah. But
Sure.
high risk, extremely high risk. I'm trying to think what else is, so many things are changing. They're doing studies that are great, and they're finding new ways that moms can, have the supports that they need and that kind of thing. Suboxone is, or Subutex is great. The thing, because they're not going to use the naloxone, but the thing with the methadone, even though it's much better for infant not to withdraw like that, is that contact mom has with going to the clinic every day and being observed. Where with Suboxone, you and I know that they'd have to go to their OB, and they would probably get Suboxone for 1 week to a month, and then not have that connection for substance use. And as far as I know, except for one practitioner I met who was from Cooper, when we were going to, just looking at the way different people were presenting, not many of the OBs really are that savvy about substance use disorders unless they specialize in it. They're few and far between. Very few and far between.
Janaea Marcellus, are you seeing pregnant women in inpatient detox coming into treatment with more medical illnesses due to laced drugs?
Well, I'm going
to out there, and we are seeing some maternal deaths, actually.
And I'm going to tell you, we're talking about pregnancy here, but I don't know if any of you have seen Trank, if you've seen xylazine. I have had 3 patients that had xylazine, okay? And I honestly thought this woman had the stigmata. So if anybody's Catholic, the flesh was so rotten on both of her hands, and the smell was so bad, and her pain was so excruciating that she just really had all this necrosis. A second one I had like craters on her legs of necrotic tissue. So, they think that they're getting opiates. They're coming from Kensington. If any of you know, we're in an area very close to Kensington. And what my patients have told me, which, you really learn from patients, is in Kensington, the people who are pushing substances there will bait our patients or on the street to try these new drugs that they're designing just overnight. And these patients are so hungry for some kind of a high that they'll take whatever the offering is, like you're going to Baskin Robbins for a new flavor. And these women are really being used and abused. But one of my male patients told me, and I still couldn't believe this, 4:00 every day at Kensington, an ambulance come by, and they call it toe tag up, where they just go and see if they can wake people up or not and take them away in body bags. That's how bad it is. So we have to stop thinking that we're going to wait for our patients to hit bottom. We can't afford that anymore. These people are gone before depending on what they get or what they think they're getting. Okay. We really need to keep people we have in treatment and engage them, and really try to stop people who are trying to AMA. Now, I don't know what state you're from. I wish we did know, but in New Jersey, we don't have a Baker Act or a Marchman Act. So we cannot hold somebody, even if we think that they're really going to do harm to themselves from substance use. I know, like Florida, you have your Baker Act, your Marchman. We don't have that. We don't have that luxury.
Jill's
And
asking if it's Kensington, PA. Yeah, Kensington,
yes.
Philadelphia. Yeah,
Yes.
it's Philadelphia.
Yeah. In fact, I had a patient who told me that she had a sister who was in high school and they did that documentary on Kensington. And the kid was watching the documentary in school and saw her sister in the documentary and like had a fit. It was like so devastating.
It's called the beach.
Yeah.
It's
And
it's a sight to see. I've
Mhm.
been down there and it's scary.
Yeah. And my patients call it ground zero.
Does your hospital have a peer support specialist? Um, it it varies. I know in South Jersey we do have some peer support specialists. Um,
Well, I'm going to tell you, New Jersey as a state trains the peer support specialists. Now, where they're located throughout the state depends on who's going to decide that they want to do this kind of work. But like I'm in Monmouth County, and all of our hospitals have access to navigators, peer support that come out with all overdoses. And in New Jersey, they also in the field, our paramedics are allowed to give Suboxone.
yeah.
They're a Narcan. So at least when the peer navigators are there, the patients actually are not so uncomfortable that they're feeling their eyelashes grow and their nails grow, that they can actually have a conversation with the navigators and be somewhat comfortable to help them make decisions. So that's a good thing. And I heard that went national, but I know it started in New Jersey over 2 years ago.
Well, I know New Jersey has it, and Cooper does it.
Yeah.
Yeah, for the EMT.
That's with, yeah. So that's
it's
what
called a bridge, and then they'll bridge them to the substance use, the addiction center that's connected with Cooper.
And even if they, like many times the patients refuse to go with the paramedics, they could still give them 3 days worth of Suboxone to bridge them to getting help somewhere.
Yeah.
That's life-saving to me. We have to stop being punitive here, and this whole thing with hitting bottom is long gone. We can't afford to do that anymore.
No.
Or wait until the patient's ready. Like, okay. I think it's like having a second grader that doesn't want to learn math. Well, does the teacher just say, well, he just doesn't want to, we have to do everything we can to try and engage them. That's yeah.
Definitely.
Yeah. How about, hey, Tone, can we see other faces? Who's there? I want to see how many
You need to stop your share.
Yeah.
Oh, stop your share so we can see who's there. I want to know where are people from? I mean, I know my Carolyn Jules here. Hi, Carolyn. But everybody else.
Hi, Carolyn. Hi, Jill. And
so who's from any place but New Jersey?
I'm from Colorado.
Oh, okay.
Okay. So what are you seeing in Colorado?
I work in a substance treatment center. So we do have in our outpatient clinic, we have a specialist who treats OB patients over at the hospital, and then they'll come to see us here.
Yeah. So they get bridged to you, right?
Yes.
Yeah.
And it's really nice because Dr. Klee really knows addictions and she knows OB. So it's really nice to be able to treat those patients.
Yeah. And making it seamless like that, having somebody that knows both specialties is perfect, right?
And I think it's the best care that OB patients can get.
I felt that way about Jersey Shore Addiction Services when we got involved with them. I felt that. I worked for them many years ago, and I think they do a very good job. How about anybody else? What are you seeing on this topic?
Yeah, I see Jill's from Maryland. Pretty progressive state. Yeah.
Yeah, I actually am not working I'm not working clinically at this point. I do support basically advocacy and teaching on a behavioral health intervention that is used digitally, and it's for contingency management and CBT, motivational interviewing. And basically the pregnancy population is they really benefit from this kind of support, but it's just not funded.
Absolutely.
That's a shame because because the consequences, look what it costs.
I know.
You know what I mean? The consequences, look at the cost.
Yeah. Yeah.
I mean,
So
border babies don't go cheap. You know what I mean? This is, yeah, seriously.
it's very sad. So yeah.
Yes.
And I just always had an interest in pregnancy and postpartum women. Just a special group. So yeah, and I really enjoyed your presentation.
Oh, thank you. That's very nice.
I'd love to know what organization is you're working with on the contingency management, Jill.
Oh, well, I work with a company called Dynamic Care Health. And so it's a company. It is an organization, but it's not a community organization or a recovery organization.
It's for profit.
Yeah, it's actually it's a small company, and but they have a lot of data. And if you wanted to just talk offline, and I'd be happy to, I'll just put my name and contact information.
Thank you.
In the chat bar. But it really, yeah, just to all of you, like regardless of if you're using it manually or digitally, but contingency management is highly effective for stimulant use disorder and all substance use disorder, but especially when we have OUD with StimUD. And it's just, sadly, it is just not funded yet. But the data is there, and in any other disease state, there would be much more attention because it like doubles outcomes rates, abstinent rates, and increases by almost 50% the time in treatment. So it's just all behavioral health intervention needs to be looked at more carefully.
So
Jill did a
me,
webinar a while ago that you could probably find on the archive and view it and get the CE if you want.
Yeah.
I thought your name was familiar, and that's why. Because I thought your name was familiar. Yeah.
Oh, and they're doing a pilot in California under Medi-Cal in several clinics and in tribal clinics as well. So we're watching that with excitement. We had a contingency management program because that's really the substance most abused along with opioids that we're seeing. Of course, alcohol is the granddaddy of them all, but largely it's the stimulant use disorder that it really derails people off of opioid use disorder treatment and stability, what we see. And so using a contingency management in addition with MAT has been really helpful. And it was stimulant use disorder in our pregnant recently that created such challenge. She was able to be stabilized with the Subutex, but her stimulant use just continued further than any of us wanted. She ended up delivering a healthy baby, and they're doing well. So I'm glad for that. But
you see,
really
this is
this.
Do you find that there's a multi-use? Do you find that the population has a multi-use, not only
that's the word.
No, the whole polysubstance thing is more because I have people that come in and their drug screens pop for so many things that they never, they're just mixing so much stuff. And the real kick right now is even the people who are using opiates and really like, even with fentanyl, now they only use fentanyl. It used to be, you have fentanyl, right? And they're putting a stimulant in there, which grabs them. And so they said, I don't even get a nod. And then they get hooked on the high. So our poor patients, there's no such thing as being an educated consumer when you're dealing, you're buying from deal. So they'll come in even with marijuana and light up for things that I don't use that. Well,
and that's what we just were told is you cannot assume that they're using one thing. They cannot assume they're using one thing. And one thing I heard that I wanted to check with you ladies is that a woman was using alcohol and Red Bull so that she would get that, combination effect. And I had not heard that before. Is that something that's common in your practices?
Yes.
Okay. Well, there's anything that's uncommon. I work in a 501c3. All my patients are on the street. You know what I mean? They're. So I mean, it's the thing is, they're very sick, and we're like the Statue of Liberty. Bring me your, you don't have money, come anyway, But there's so many things that would I'd love to do with them, I'll never get cleared for. Never.
Mhm. I'm in
Ladies,
a-
thank you. We need
Oh,
to
yeah.
end this now. We're
Oh,
going
sorry.
way over
You know what,
time.
Suzanne, I wanted to say thank you for this
Thank you.
type of platform where we can really, like,
Yeah.
everybody can join in and we can find people from all different states that are interested in this topic, and we appreciate having that platform.
Yeah, this networking is really important. And for you guys, I hope whatever it is you guys are doing, it works out. You do.
Yeah.
Thank
Okay.
you, Tony and Rosemary. It
Thanks.
was great. Obviously, people are really enjoying what you have to say.
Oh, that's
geez.
great. We appreciate you too.
Yeah, no, appreciate you guys. Thanks
Yeah.
for showing.
Thank you.
Okay. Bye now.
Bye.